she was saying about Cushing syndrome, and she said about ectopic ACTH secretion and said about oat cell carcinoma of the lung associated with that. So I was saying associated along with the myasthenic syndrome and the myasthenic gravis, which we spoke about earlier. So when we said patients could have this problem, I was just telling them as postgraduates, you need to connect whatever you're reading earlier and today and subsequently. So that's what I was telling them.
Good evening, sir, and good evening, madam, and my dear students and Raisa colleagues. I welcome you all once again for this Railway Association of ISA online DNB academic activities. Today we have with us Professor Nagasamy sir and Professor Vasanthi and Professor Salamani and my dear students. And we are here for exam going topics, important topics, and one small case scenario presentation by Dr. Ashmi from Sri Balaji Medical College. And so followed by anesthesia machine and workstation, a question and answer session, and drugs and IV fluids discussion with Professor Nagasamy and Professor Shanti madam. I hand over the session to Professor Nagasamy and Professor. Thank you, sir. Thank you, madam.
You are Dr. Rashmi. Are you able to hear me?
Good evening, sir.
Good evening.
Shall I?
Clearly audible?
Yes, sir. Am I audible, sir?
Yeah, you are also audible. You know the case scenario.
Yes, sir.
So, what is your approach to this patient?
Shall I present the case, sir?
Yes, yes, yes.
Okay. I'll just share my screen with the notes that I've made, sir. Good evening. So the case that was given to me today is a 15-year-old boy who complained of progressive weight gain, dry skin, which easily bruises, diagnosed as a case of Cushing's disease, and sustained tibial fracture while playing, and is posted for ORIF. So, like I said earlier, Cushing syndrome is any condition where there is increased plasma cortisol levels. I just wanted to brief about the syndrome and disease. So to understand this better, the pathophysiology of the Cushing's is that whenever the body undergoes any stress, the hypothalamus releases your CRH, which stimulates your anterior pituitary to release ACTH, which in turn will stimulate the zona fasciculata layer of your adrenal cortex to produce cortisol. When this cortisol is above the level, when there is too much of production of cortisol, there is a physiological negative feedback mechanism happening in the body, which inhibits your CRH release, which in turn helps in maintaining the cortisol levels within limits. So the main pathology of Cushing's is that this negative feedback mechanism is inhibited in Cushing's. So Cushing's syndrome is a condition where there is increased plasma cortisol levels, and Cushing's disease is basically a benign tumor which is located in your anterior pituitary gland, which secretes too much ACTH. In turn, there is more of cortisol production, and there is no maintenance of the level because your negative feedback mechanism is also abolished. So your normal cortisol levels are usually synthesized more in the daytime around 6 to 8 a.m., which is around 10 to 20 mics per deciliter, and from 4 p.m. onwards, it is said that the production rate reduces to around 3 to 10 mics per deciliter. So Cushing's can be because of an iatrogenic cause where there is overuse of exogenous cortisol. So this we can see in patients with asthma, rheumatoid arthritis, SLE. It can be because of an ectopic syndrome wherein there is tumor in the adrenal gland secreting excess cortisol, or a tumor elsewhere in body, mainly a small cell lung carcinoma producing a lot of cortisol. And Cushing's disease, like I said earlier, is the disease of the anterior pituitary. A benign adenoma of the anterior pituitary. So glucocorticoid excess in Cushing's is a common cause of secondary osteoporosis. So it is said that around 30 to 50% of patients with Cushing's experience non-traumatic pathological fractures, which is often the presenting symptom of the disease. So coming to the clinical features of the disease, we'll have basically there's hypertension because of alpha-1 receptor stimulation. There's osteoporosis, patients present with osteoporosis or brittle bones. The pathology, see, glucocorticoids basically affect the metabolism of bone in two ways. I would like to talk about osteoporosis first. So that either it acts in a early rapid phase or in a slower progressive phase. In the early rapid phase, it inhibits your calcium metabolism. So there is increased excretion of calcium and decreased absorption of calcium from the gut. Because of this, there's also increased osteoclast activity, and it also increases your parathyroid hormone levels. So because of this, there is increased bone resorption. In the slower progressive phase, the osteoblast formation and function is reduced, which causes impaired bone formation. Other than that, it also inhibits the alkaline phosphatase activity, your collagen synthesis, and your bone protein like osteocalcin synthesis is reduced. Because of all these conditions, only the patients are more prone to pathological fractures. So that is one of the clinical feature, osteoporosis, like the patient that we have right now. Other than that, the patient can also present with proximal muscle weakness within extremities. This is because the cortisol breaks the muscle for amino acids, which has to be used for gluconeogenesis. The patient present with a characteristic moon facies, buffalo hump, and truncal obesity because of increased fat deposition. There's increased ACTH and hyperglycemia, and the patients are prone to diabetes. Abdominal striae and increased bruising can occur because of impaired collagen synthesis, so there can be thinning of the skin. Patients present with central obesity in CNS, there can be irritation, generalized weakness, fatigue, vertigo, mood swings. Women commonly present with irregular menstruation and hirsutism. Men present with erectile dysfunction, and children usually present with slow or stunted growth. So coming to the diagnosis of the disease, so clinical suspicion along with the patient's medical history, examination, lab test should help us to rule out the increased cortisol levels in the blood. The 24-hour urinary cortisol test can be done, and a level of more than 50 to 100 mics per day is diagnostic. The most diagnostic test is your low-dose dexamethasone suppression test, wherein dexamethasone of 1 mg is given to the patient in the night. The following morning, blood is drawn and checked for cortisol levels. Like I said earlier, the negative feedback mechanism in Cushing's is destroyed. So because of this, a patient with Cushing's disease will present with increased cortisol levels in the morning, which is almost equal to 5 mics per dl. Wherein a patient without Cushing's will present with low cortisol levels, almost less than 1.8 mics per deciliter. So this is the most diagnostic test. Like I said earlier, cortisol synthesis is lower in the night. So a high cortisol level in your saliva in the late night is also diagnostic of Cushing's. Other tests to rule out Cushing's include your MRI of pituitary gland with gadolinium enhancement for any pituitary tumors. CT of adrenals can be done if any adrenal pathology is suspected, and CT of chest, abdomen, pelvis to rule out ectopic site suspicion. Coming to the treatment. So treatment of Cushing's basically depends on the underlying cause. If it is due to an exogenous medication, you gradually decrease the dosage rather than rapidly stopping the medicine, because the patient can end up in adrenal crisis, which is life-threatening. If it is due to a pituitary adenoma, like in Cushing's disease, transnasal sphenoidal sinus endoscopic excision of the pituitary adenoma is done. Likewise, if it is a adrenal pathology, adrenal tumor, laparoscopic excision of the adrenal tumor should be done. For medical treatment, we give the patient some adrenal steroid inhibitors like ketoconazole around 600 to 1200 mg per dl, metirapone, which is 2 to 3 grams per dl. Other than that, we can also give them mitotane 2 to 3 grams per day and mylglutamide 1 gram per day. So before coming to the anesthetic management of the disease, the possible considerations that we should keep in mind is that the patient are usually obese because of the central obesity and fat deposition. So they will have, we should always rule out possible, we should always anticipate possible difficult airway and OSA, obesity related complications as well. In CVS, these patients are prone to hypertension, LVH, RVF, systolic diastolic dysfunction, hypertensive and volume overload status. RS patients usually, we should anticipate pulmonary aspiration due to obesity and GERD. Metabolic, hypokalemic metabolic alkalosis, diabetes, osteoporosis. In CNS, possible psychosis and mood disturbances. Pharmacological consideration where these patients are usually sensitive to neuromuscular blockers because of the proximal muscle weakness, and cancer consideration should also be there. So coming to the anesthetic management. So pre-op evaluation and optimization, a proper history of depending on all the signs and symptoms elicited should be taken. And on examination, the general condition, the weight of the patient, BMI of the patient, and vitals monitoring, BP monitoring is very important. Airway examination is very important to rule out any, and we should look for predictors of difficult mass ventilation and difficult intubation. Basic routine investigations we have to do is CBC, RFT, LFT, electrolytes, blood sugar workup, chest X-ray because they can have, and to rule out kyphoscoliosis, osteoporosis, LVH, CA, bronchus, ABG to if there's any suspected respiratory comorbidities, pulmonary function test. Because these patients are, because of obesity, they are prone to post-op ventilatory failure. PFT, we should specifically look for any restrictive component. ECG echo for valve structure, valve dimensions, pulmonary hypertension, arrhythmias. Endocrinologist opinion, pre-op and post-op is mandatory. Like I said, these patients are often hypertensive and hypovolemic because of RA system activation. So because of the mineralocorticoid activity, sodium fluid retention and potassium excretion is there. And because of this, vascular sensitivity to catecholamine and angiotensin 2 is there. So because of this, patients are usually hypertensive and hypervolemic. So all the drugs can be continued till the morning of surgery except ACE inhibitors and ARBs, as they are associated with severe hypotension with standard anesthetic induction and spinal anesthesia. So the drugs used to inhibit the release and synthesis of glucocorticoids, like the drugs that I've mentioned before, must be continued preoperatively. Cushing's is because of like the mineralocorticoid activity, they are associated with hypokalemic metabolic alkalosis. I'm sorry, it's not acidosis, alkalosis. So potassium sparing diuretics will decrease the potassium loss. Spironolactone is usually preferred. Apart from that, because there's hyperglycemia, you always stop the oral, they can be hyperglycemic. So you pre-operatively, you stop the oral medication and start them on insulin, and according to sliding scale, the goal is that perioperative RBS of around 120 to 180 mg per DL should be maintained. Serum calcium levels, parathyroid levels also should be looked upon. Obesity and obesity-related complications can be there, so we have to rule out all of these. Because of alpha-1 stimulation, there can be increased blood volume, cardiac output, ventricular overload, O2 consumption, and CO2 production. So ultimately, there's systemic pulmonary hypertension or pulmonary right ventricular failure. We should also, there's also LV dilatation because of increased LV wall and hypertrophy of the left ventricular wall because of systemic hypertension. So final end result is your ischemic heart disease. Apart from that, because of all the coexisting conditions, hypercoagulable state and immobility, they are at increased risk of DVT and pulmonary embolism. So prophylactically, we can start them on low molecular weight heparin if necessary, or lower extremity compression devices can be given. Early mobilization is also helpful. These patients are at increased risk of aspiration because of obesity. So we can prevent using metoclopramide 10 mg IV. We can give ranitidine 50 mg IV and sodium citrate 30 ml orally before shifting to OT. Coming to the intra-op management of the patient, I would, after properly explaining the risks of the patient and getting proper consent, we shift the patient to the OT, and we should carefully position and pad, careful positioning and padding of the patient is necessary because they're prone to fractures and they also are prone to skin damage. Standard monitoring like temperature, NIBP, ETCO2, pulse oximetry, ECG should be connected. Adequate size BP cuff should also be there because they are obese usually. Invasive monitoring depending on the patient's cardiac reserve, like A-line Schwann-Ganz catheter for pulmonary hypertension, large bore peripheral vein catheters, and C-line can be secured for massive liquid and blood transfusion if necessary. My preferred anesthetic mode for this patient, sir, would be regional anesthesia because with GA, there is increased risk of, because of obesity, there's increased risk of complications related to obesity, like starting from the airway, difficult mass ventilation, difficult intubation. And also the advantages of regional over spinal is that there is inhibition of the stress response. Your metabolic and hormonal responses are inhibited. Also, there is reduced incidence of post-operative pain, reduced incidence of DVT, early mobilization, and polypharmacy can be avoided. So, intraoperatively, adequate fluids should be given RL/NL at 15 ml per kg. Perioperative management of hypertension, hyperglycemia, IV fluids, and because it's a volume overload status, and electrolytes because they're giving attention to hypokalemic status is a must. Insulin infusion can be started, bolus of 0.1 units per kg, followed by 1 unit per kg per heart can be given. Frequent blood sugar monitoring. And in fluids also, we can give RL or NS and avoid dextrose containing fluids. Post-operatively, post-op vitals monitoring and is a must. Effective post-op pain relief. The proper wound care is also a must because they have delayed wound healing and they have increased susceptibility to infection. The cortisol, glucose, and electrolyte level should be routinely checked. Early mobilization to prevent DVT and pulmonary embolism, and endocrinologist evaluation post-op is also mandatory. Thank you.
It's a fairly very exhaustive preparation. Nice. Congratulations. As you said earlier, it's very important to distinguish between Cushing syndrome and Cushing's disease. You said Cushing disease could be due to secondary to pituitary problem, correct?
Yes, sir. Yes, sir.
So how safe it is to give a spinal for a patient with an suspected pituitary adenoma or something?
Sorry, sir.
How safe it is to administer a spinal if the patient has Cushing's disease with a pituitary tumor which has not been detected?
The first, I'm not able, it's not audible, so I'm sorry. Can you repeat the question, sir?
Now, are you able to hear me?
Yes, sir. Yes, sir.
Okay. Now, you said your preferred technique is regional.
Regional, yes, sir.
Correct? Okay.
Yes, sir.
Supposing it is a case of Cushing's disease.
Yes, sir.
Due to an increase in the pituitary size.
Yes, sir.
Tumor, not diagnosed. Because this is a fracture which is coming as an emergency. Supposing
Yes, sir.
you have not done an MRI to find out the Cushing's pituitary problem.
Yes, sir.
Is it safe to administer spinal for this case? In other words, what are the precautions you should take in these sort of cases when they come as an emergency? Do you have any clinical features because of the pituitary increase in size? Any clinical history or symptoms which can point to the presence of adenoma in the pituitary causing this problem? One of your points that you mentioned is you have to do a resection, a transnasal resection of the pituitary.
Yes, sir.
Isn't it?
Yes, yes, sir.
You mentioned.
Yes, sir.
So supposing that is the situation, and in
Yes.
an emergency nature of the disease and the injury, If
Yes,
you
sir.
are not investigated from that angle, will it be safe to administer a spinal? In other words, can you clinically, by asking few things, questions to the patient, can you detect the presence of a pituitary tumor? Any visual problem which can happen if there is a
What else can the patient have? What else
Yes,
can
sir.
the patient have? What other symptom can the patient present with?
In other words, you should know what are the features of a pituitary adenoma. Supposing the pituitary gland has enlarged,
Yes, sir.
what are all the other features it can present in the to the patient? See, where is the location of the pituitary gland? Which part of the circular system is there? Is there a bony covering to enclose the pituitary gland? Have you heard of sella turcica?
Yes, sir.
Ah.
Yes.
So supposing the gland becomes bigger and bigger, the
Yes, sir.
pituitary gland becomes bigger, what will it do? What is the nearest structure close to the pituitary gland? Have you heard of optic asthma?
Sorry, sir.
Optic asthma.
Yes, sir.
So if the gland increases in size and presses on the optic asthma, what will the patient will have?
Visual disturbances
What
because
type of visual disturbance? Have you heard of hemianopia?
yes, sir. One side.
That's a very, very easy way to find out. Okay,
Yes.
supposing the patient says he can see only one half of the field, he's not able to see the medial
Yes.
half. Okay, that question should always be asked in all these patients. That is the simplest way to find out the presence of a pituitary tumor.
Pituitary. Okay,
It's
sir.
a hemianopia. Okay,
Okay.
patients may be managing with that, so they may not tell you that it is a problematic thing for them. But if you probe and ask them, they will tell you, yes, I can see only one half and I am managing somehow with that. I have seen a doctor, ophthalmologist, and he said they will have something pressing on your nerve going from the eye. And that is the reason why you are having this. You may need to get resected. So, everybody should know the difference between a Cushing syndrome and disease. Syndrome is only the presence of excess cortisol in the body. That may be due to any reason. But when you say it's a Cushing's disease, it is a primary defect in the pituitary gland, which is secreting more of ACT, which to stimulate the cortex of the adrenal gland to produce more cortisol in the body. Okay, so that disease, if you operate on the patient and remove the adenoma or the tumor from the pituitary, patient will revert back to normal. On the contrary, for other conditions, you may have to, as you said, withdraw the amount of steroid that is being used for other conditions like bronchial asthma or osteoarthritis, all those points you mentioned. So one more question they can ask you is, what are the equipotent doses between the various forms or preparations of cortisol that you can administer clinically? For example, how much is equivalent to dexamethasone, equivalent to prednisolone, how much is equal to methylprednisolone, hydrocortisone. These are the 4 common preparations that we use clinically. Are you able to hear me?
Yes, sir.
So what is the equipotent dose between dexamethasone, prednisolone, methylprednisolone, and hydrocortisone? For example, dexamethasone 0.75 milligram.
Okay, sir.
How much is prednisone equal to? How much is methylprednisolone equal to? How much is hydrocortisone? Equal to 0.75 milligrams of hydrocortisone. Dexamethasone. So it is equal to prednisone 5 milligram, methylprednisolone 4 milligram, and hydrocortisone 20 milligram. Okay. So this knowledge is important because patients may be taking various preparations.
Yes, sir.
Whenever they come, and if you don't have that particular brand, and if it is probably they are taking a oral preparation and you don't have that oral preparation to administer, you must do the parenteral preparation, which you can safely administer to supplement that. So equipotent doses between dexamethasone, prednisone, methylprednisolone, and hydrocortisone should be
1.5 mg.
Then the other important thing is, supposing a patient has been taking steroids for a long time, when is the necessity to supplement? Do all patients require supplementation, or are there any criteria to?
Yes, sir. For any superficial surgeries, we intraoperatively we give them the daily dose only. For minor surgeries, we give them the daily dose plus hydrocortisone, 25 mg IV. For moderate surgeries, daily dose plus hydrocortisone 50 to 75 mg, which should be given in 1 to 2 days. And major surgeries, they should get the daily dose plus hydrocortisone 100 to 150 mg, which is tapered to 1 to 2 days.
So that is also a very important point that we asked, which you should be able to learn. So the main points in this problem, in this case, you have to mention is the airway problem, the obesity problem. All those system-wise, you have beautifully covered everything. So all students should remember that these cases have that problem of obesity, OSA, airway difficulty, that especially the fat deposition in the back is called the hump in the back. Will definitely interfere with the positioning of the patient, both for airway management as well as for surgical management. So majority of the patients who are in extreme the category of Cushing's may not be able to lie flat on their back for surgeries which are done in the supine position. So you have to plan for all those things, give them proper support so that they don't find it uncomfortable, especially if you are planning for regional. You must make their lying down for the duration of the surgery as comfortable as possible. And another thing is their skin is so brittle that it can bruise as well as get injured very easily. So pressure points should be taken proper care of. Otherwise, they will develop pressure sores in no time. And that will take a long time to heal. And they may be immunocompromised also, because this cortisols, they suppress the immune system. So they are immunocompromised, or they catch up any infection very fast, and that will be masked. That is another important thing. So they must be, you must exhibit utmost sterility to introduce any infection hydrogenically, and also give them a good antibiotic cover so that they don't harbor an infection without the evidence of inflammation. They won't have any fever, they won't have any features of regular inflammation, because cortisol is likely to suppress all the inflammatory response. So you have to take care of that also, is very, very important. And especially when you plan for GA, laryngoscope, your tube, everything should be kept very sterile so that you don't introduce any infection into the lung, and they can develop very severe post-op pneumonia complications. Okay? This is the point that you have to remember. And with the dexamethasone suppression test, you said that 1 milligram, they say you have to specifically tell the time.
At 11 o'clock in the night.
Between 11 to 1 a.m. you have to administer, and measure it at 8 to 9 a.m. Okay, so that much of gap should be there. And then you get the correct person. Okay? Right, very good. You are nicely prepared.
Sir, 1 minute, sir. So from what I referred, sir, regarding this dexamethasone suppression test, in one, I think BJ, I'm not sure where I saw, I think it's BJ. They said that it's a screening test.
No, there are two tests. One is to find out
establishing,
to find out ACT is dependent and independent. So
yes, sir.
That is the way they classify this test.
So establishing the cause, they said we have to use the high dose dexamethasone, 2 milligram
that is
dexamethasone suppression.
Yes, one is diagnostic, another is the severity. So
yes, sir.
That is how they classify.
So I thought, because Rashmi said so much, I thought maybe she could also say a little more on that.
Well done, Rashmi. It was a good presentation.
Thank
you.
Thank you.
Thank you, sir. Thank you, ma'am.
So,
thank you, sir. Thank you, madam. Thank you, Dr. Rashmi. Shall we move on to the next part of the session, sir?
Yeah. go to the next one. Can I share my screen? So all the DNB postgraduates who are awaiting their practical exams in the month of June. Machines is a very important topic. Of course, this is not the time to start from A to Z and go in detail. That will take at least 3 to 4 hours. So we'll just try to show pictures and try to see whether you are able to identify. So it's a session where you have to participate. It is not the time myself alone going to be talking. And I would like to know how much you are able to identify each and every part of the machine and what are all the common questions that you will come across. So this is not a regular presentation on the topic of machines. It is rather a sort of mock viva for you. So I will just show you. You may not have the entire answers available, and it is from your from participation we are going to get the answers.
It's visible.
Kamakshi, I want to add one more point.
Yes, madam. Please, madam.
Thyroid, being an anterior pituitary secreting hormone, you have to check thyroid also. Thyroid level of the patient.
Yes, ma'am.
The screen visible?
Yes, ma'am. Yes, sir. Yes, sir.
Okay.
Thank you, madam. Thank you.
Thank you, Rashmi, for that.
Thank you, sir.
So, can all of you, those who know the answer, can unmute and then answer. Can you identify this machine? Any one of the students know the answer? You can. Rashmi also, if your mic is on, you can answer. Can you just identify this machine?
It's the boils.
Working apparatus, sir.
Boils apparatus, oldest or a recent one?
Oldest.
Older.
Oldest. Okay. What is the difference between an older machine and a newer Boyle's machine?
It has only mechanical and only mechanical.
Mechanical. What is mechanical? Pneumatic.
Pneumatics.
Don't say mechanical. It is pneumatic. Okay. It is pneumatically operated. Okay. Now look at the picture. Because it is not shown in the frontal view. It is shown in the lateral view rather. So can you identify what are all the parts in this machine? I will just put my pointer there. You can just tell me what is this. Do you see my pointer rolling over there? Is it visible? Hello?
Pressure.
Huh?
Pressure
Pressure
gun
gauge. Pressure gauge for what? Which gas?
for oxygen.
See, the color is there. And my pointer is, where is it? It is here, not here. This one? That's it. It's blue in color or white in color?
Blue.
Blue, sir.
Blue.
Nitrous.
So, so don't make a mistake. See, this is color coded. Okay. So the
Yes.
color coded pressure gauge, blue color is always nitrous oxide. If it is white color, it is oxygen. Okay.
Yes.
And what do you find here? What is this portion?
Flow meters.
Flow meter. Okay. Now, what is the arrangement of this flow meter tubes? You see the knobs controlling the flow. So, what is the order? Which one is first? Which one is second? Which one is third?
Nitrous is first, sir.
Nitrous oxide is on the first position. Okay. Oxygen is in the third position. Okay. This is the oxygen.
Upstream arrangement.
Huh? Upstream, downstream.
Yes.
Which is upstream, which is downstream now? Now that you have mentioned and you have used that terminology, you have to explain what do you mean by upstream, what do you mean by downstream? How does the
Usually
air flow?
oxygen in modern mission, oxygen is placed in a downstream arrangement, sir, so that even if there is any nitrous or leak, minimum of 25% oxygen can be delivered to the patient, sir.
Here also it is only downstream. Do you think it is in upstream oxygen?
No, sir.
This is used old machine. Here also the oxygen knob you find is only here in the third position. This is the first position. You see a knob in the second position. This is the third position. So this is only the downstream. So do you think this is wrong machine? See, once upon a time it was first in the first position. Earlier machine it was in the first position. Oxygen was in the first position. Nitrous oxide was in the third position or second position. If you have
Okay.
only two tubes, okay. Whereas here they have shifted the oxygen to the third position, as you rightly said, to avoid hypoxic picture. But they don't mention about 25%, 35%, and all those things. Okay. So
Okay.
even if you have a crack in the machine, you will get the normal oxygen flow will be there. It will not dilute it. Okay. So now that you have mentioned about it, what is the arrangement in the modern machines? Do you think it is in the last position? The recent workstations, where you are doing workstations, you are using them day in and day out now, isn't it?
Yes, sir.
What is the position of oxygen in your workstation? It is in the
Sir,
third
now-
position.
Now all anesthetic machines are modified, sir. Doesn't matter to be in downstream or upstream, sir.
No. How? What is the mechanism? Why they are so confident that it can be kept downstream or upstream? This is the safety feature.
Sir, oxygen and pressure, hypoxic pressure sensor.
We'll come to that little later. So what is this? What way this machine is different from this one? Just look at the pictures and tell what are the differences you find between these two machines.
This machine is with CO2 absorber, sir.
Very good. Very obviously seen. Excellent. Then that is a very glaring difference that you are seeing. But always start from the correct end. Okay, start from the cylinder position, go to the flow meter, then come to the vaporizer, then come to the outlet, then see the circuit, then see all the soda line. Don't immediately jump to soda line. If you go in an orderly fashion, you will be able to find out all the differences. Okay?
Okay.
So now here, this machine, what cylinder is mounted here?
Blue color, sir. Nitrous oxide.
Nitrous oxide. Here, black color. You seeing a black color cylinder here?
Yes, sir.
Yes, that is oxygen. Okay. So
Yes,
there is a pressure gauge for both the things. So the common question they will ask you is, do you require a pressure gauge for nitrous oxide? Will it be of any use than nitrous oxide? Or they can modify the question like this also. What is the difference between the pressure gauge of an oxygen cylinder and the pressure gauge of a nitrous oxide cylinder in their functionality? Will nitrous oxide cylinder also show a reduction in the pressure as the gas gets emptied? Very, very basic and common question asked from the examination.
Form is nitrous oxide in the gas in the cylinder.
It is in liquid form, sir. So
Then what happens? What comes out? Liquid is not coming out, no? What comes out?
gas.
So
Vapor.
what will happen to vapors?
Pressure gauge is needed.
Hey, the pressure gauge show reduction if the vapor is getting evaporated and coming out. Will it maintain the same pressure or will it gradually reduce like the oxygen cylinder?
No, sir, it won't change, sir.
It won't show any change, isn't it? Until
Yes,
the
sir.
last drop of nitrous oxide liquid is evaporated, it will show the same pressure. Correct?
Yes, sir. Yes, sir.
Okay. Then why foolishly we are spending so much and keeping a pressure like that? If it is not of any use, it is going to show the same reading. What is the full pressure cylinder in a nitrous oxide? When you open a full cylinder, how much pressure it will record? It will show 750 psi. Whereas oxygen it will show 2000 psi. Okay, that is these are all very basic points. You should not make any mistake at all. Okay, so 750 psi will be the pressure inside a full nitrous oxide cylinder. And when you start using it, until the last drop of nitrous oxide is vaporized and utilized, it will continue to show the same 750 psi pressure. And by the time the last drop gets vaporized, it will suddenly start decreasing and then it will come to zero within no time. Within, let's say, about 2 minutes or 3 minutes time. So previously, they were not using a pressure gauge for nitrous oxide. But during certain procedures like neurosurgery and cardiac surgery, when they were using nitrous oxide as part of the anesthetic mixture, a sudden complete drop or loss of nitrous oxide will make the anesthesia lighter or deeper?
Lighter.
Lighter. Okay, so they were finding it difficult to replace the cylinder because only the flow meter will suddenly come to zero and oxygen alone will be flowing. So patients were made to become lighter in a plane of anesthesia, which is very hazardous for a neurosurgery or cardiac surgery. So in order to know that the cylinder is getting empty, they attach the gauge which will start falling. So the moment you know the cylinder is trying to, the needle is coming down, the cylinder is getting empty, so you can immediately open the new cylinder or replace it faster with another cylinder and then maintain the same flow of nitrous oxide that you get. That is the only purpose for which this gauge was used. Okay. Otherwise, this gauge doesn't have any value to show what is the amount of nitrous oxide left in the cylinder. Okay. This point should be very clear in your mind. So if you answer that correctly, that the gauge will read only during the last drop or the last few milliliters of liquid that is getting evaporated, the next question the examiner may ask you is, then what is the method of finding out what is the amount of nitric oxide that is left?
By touching the cylinder by cold sensation, sir.
Cold sensation. So your hands are so sensitive to find out the cold sensation. The answer is may look stupid, but the only way is to weigh the cylinder and find out. Okay? The best method of finding out, supposing in between, of course, you can't do it. But if you want to find out in between the cases, you have started using it for morning first case, and you want to know what is the amount of nitrous oxide left behind, then you have to remove the cylinder, weigh it, and then find out the difference between the full cylinder and the cylinder that has been in use. Then that difference only will help you to find out what is the amount of nitrous oxide left in that. Okay. So weighing the cylinder is the only method of finding out the residual amount of nitrous oxide left in the cylinder. Whereas pressure gauge that is used for oxygen cylinder, that is very useful. Find out what is the volume of gas that is left inside. So what is the capacity or volume of oxygen you will have in a, what is this type of cylinder that is attached to the machine called? How they are named? Any alphabet? any alphabet that you want to use, name the cylinder. The cylinders that are attached to the machines like this, do they have a name according to the alphabet? It's called the E-type cylinder. Okay, A, B, C, D, E, F, G, H. Okay, this is a very, very basic fundamental point you all of you should know. So it is called an E-type cylinder, and the capacity of an E-type cylinder is 660 liters. Okay. So the pressure gauge will read 2000 psi if the cylinder is full. Supposing that the pressure drops to 1000 psi after usage, what will be the, so 2000 psi will have 660 liters of oxygen. Supposing it becomes 1000 psi, what is the amount of oxygen left inside?
Sir, 330. Half the amount of oxygen will be consumed.
330, half the amount, exactly. So if the pressure becomes 1/4, the cylinder also will have only 1/4 of the capacity. Okay. So in that way, the oxygen pressure gauge is very useful to find out what is the volume of gas that is left in the cylinder, so that you can calculate. Common question the examiners used to ask is, you are going for the emergency cesarean in the night. Patient is posted for emergency LSCS, and there is some contraindication for giving spinal, and you have to give GA. You are checking the machine, and you find the oxygen cylinder is only showing a pressure of 1000 psi. The other cylinder is empty. There is no other cylinder in the hospital. Will you start and give anesthesia for this patient or not? And you know your surgeon can finish the surgery in half an hour to 45 minutes time. So if you are confident with your surgeon, will you go ahead and do the surgery or not? How will you know that it can last for the particular duration of surgery? This is a common question they will ask you. So if the gauge shows only 1000 psi, that means it is only half full. Half the gas has been utilized. So you have only 330 liters of oxygen left in the cylinder, right? And if you are going to use 2 liters per minute, for 1 hour you are going to use 120 liters. So 330 divided by 120, you will have roughly 3 hours oxygen available if you are using only 2 liters per minute. Okay? And if your surgeon is confident he can finish the surgery by 45 minutes, you can give. But this is the theoretical calculation. You should never, never, never operate or give anesthesia without a spare cylinder in the Boyle's machine. If you are a safe anesthetist, you should insist that there should be a full cylinder spare available all the time in the machine, because you do not know. Suddenly, the cylinder that you are using may start leaking, and all the gases may get emptied in no time. At the time, if you don't have a spare cylinder, you will be putting your patient to a very great risk of hypoxia. So, even for theoretical calculation purpose, we can say that a half cylinder, if you are going to use 2 liters or 3 liters, may come for 2 to 3 hours easily. But that should not be the criteria for starting the case. Okay, so that is all. And what gas law is used for calculation of this? That is another common question they will ask you. What are the basic gas laws?
Boyle's law, sir.
Boyle's law, Charles' law,
Avogadro's law.
Avogadro's hypothesis. Avogadro's law. Gay-Lussac's law. Charles' law, Boyle's law, Gay-Lussac's
Henry's law.
Okay. So which law is utilized here for calculating the
Boyle's law.
Boyle's law? Okay. So that is another common question they will ask you. Right. So that is about the cylinders. Because we will have to ask a lot of questions on cylinders are there. So you find one vaporizer here and 2 vaporizers here. Can you identify what is this vaporizer, what is this, and what is this? Fortunately or unfortunately, if you go to a center which has got all the old machines still in usage or as a machine specimen examination, they will keep those machines and ask you all these questions. So it is better that you now learn it so that you can answer those questions in the exam. Can anyone identify what is this temperature? Or at least this one.
Goldman vaporizer.
Goldman vaporizer, okay. What about this one? This one?
Boils bottle for ether.
This is not Boyle's bottle. This is much thinner. Boyle's bottle will be bigger. I'll show you the picture to identify. This is a trilene bottle. Okay. A long thin bottle is a trilene bottle. What is this? What vaporizer? This is the modern, the forerunner of modern vaporizers. The oldest of the modern vaporizers. This is a vaporizer for halothane. When it came into market, this was the vaporizer for halothane. Okay. Just like your car model, the vaporizers are given all the Tech 1, Tech 2, Tech 3, Tech 4, like that they were named. Okay. What does the Tech stand for? One called series of Tech vaporizers. Tech stands for temperature compensated. Okay. Whereas here there is no temperature compensation. Here there is no temperature compensation. Whereas these vaporizers are temperature compensated so that at any ambient temperature it will deliver the same concentration of the volatile agent that you have set. So, is this a workstation or is this still a Boyle's machine?
Anesthesia workstation, sir.
This is a workstation. Are you confident? Are you 100% sure? Why do you say it is anesthesia workstation?
It has a pneumatic component and an electric component, sir.
Where is the electrical component in this? Can you just try to see this picture and identify whether there is any electrical component in this?
Monitor is there, sir.
The monitor can be attached to separately to any outlet. Ventilator also can be attached to any outlet. Just because you have monitor and ventilator, can you call it as workstation? As you rightly defined, workstation should have both pneumatic and electrical components. But do you find any electrical on-off switch anywhere here? These are all pressure gauges. This is a flow meter. These are all vaporizers. These are all cylinders. And do you find these cylinders obviously seen in a workstation like this? Now you see this picture. Do you find any cylinder which is seen like this in this machine?
No, sir.
This is the workstation. Okay. So in most of the modern workstation, you will have to search where the spare cylinders have to be attached. It will be at the back.
Yes, sir.
So don't make a mistake. If you see cylinders hung like this from the yoke on the sides, it will not be a workstation. Workstation, they have hidden all the spare cylinders position. It is not seen outside at all. And you have an on-off switch in the center. This is the electrical control switch. So the workstation has both electrical and pneumatic components, and the control switch will be in the front, very obviously seen. So only when you switch it on, this machine will function. If you don't switch it on, no gas will flow, nothing will work. But only one component can operate without electric power also, which is that. In the workstation, there is a safety feature where even without switching on the power, one gas can be delivered. Where is it delivered and what gas is delivered? What is the name for that particular component? you've seen a flow meter on the side. This picture you are not able to see, but usually you have a flow meter separately coming on the side of the machine. Okay, that is called auxiliary oxygen outlet. So that you can always use even without the power being switched on. Okay, otherwise you have to have the on-off switch. So please remember the picture. This is the classical workstation. These are all various models of Boyle's apparatus. This is not at all just because you have a monitor and a ventilator attached. Don't make a mistake that it is a workstation. Okay, workstation would be classically like this with a spare cylinders nicely concealed. It will not be seen outside at all like this. Okay, so if they keep a machine like that, make sure that, or if you have a doubt, if the real machine is kept in the exam, go and look for the presence of an electrical on-off switch that will be present in the workstation only. Now, the question that I'm going to ask is, supposing you are going to a new theater, you all are successfully cleared your DNB, you have become consultants, you get employed in a hospital, and you go to a new OT first day. And you are asked to give GA for a patient, 7-year-old boy for tonsillectomy. This is the first thing you will check in the OT.
Ambu bag, sir.
Very good. So I noticed the picture already. Okay. So why you should check for the presence of an ambu bag?
Even if the cylinder goes out, Boyle's is not there, we can at least give 21% of oxygen.
Where you can ventilate, or you can attach an oxygen source and increase the airway to the desired level. So that is the first thing that you should check. Okay. So if there is a possibility that workstation breathing circuit is a potential cause of difficulty with ventilation or oxygenation, switching to a self-inflating resuscitation bag is appropriate decision. Okay, this is a very, very important. So ventilate and oxygenate first before trying to give anesthesia. So this is the classical ambu bag. Of course, ambu bag itself can be a question for itself. So this is the first thing you say. So if you are asked to trace the path of the gases and vapors that are being delivered by the anesthesia machine, where will you start? Supposing examiner tells you, I don't know whether this June exam is going to be a live exam with the machines and the examiners coming in live and then testing your knowledge, then you have to. They can ask you to trace the path of the gases. So how will you trace that? So the source of the gas supply can be from wall outlets or from the cylinders hung in the machine. Okay. So the cylinders can be from the port assembly, the side, or you can have the central supply. So where does the high pressure start from? What are the 3 pressure zones of a Boyle's anesthesia machine?
High pressure system, intermediate pressure system, and low pressure system, sir.
Excellent. So what are the components of the high pressure system?
Sir, from where the cylinders are attached to the machine, it is a high pressure system, sir. Whereas the central wall supply is intermediate pressure system, sir.
Okay.
From the flow meters, from the attachment to the yoke assembly till the flow meter, it is intermediate pressure system, sir. From the flow meter to the patient, it is low pressure system.
Cylinder, pressure gauge also, pressure gauge and pressure regulator, they are also high pressure. The pressure regulator only reduces the high pressure to intermediate pressure. Okay. So the outlet from pressure gauge or pressure regulator is the starting point for intermediate. Then up to the flow meter inlet, it is intermediate. From flow meter to the breathing circuit, it is all low pressure. Okay. So oxygen failure devices Where are they incorporated? Are they incorporated below or after?
O2 flush, sir. From the intermediate pressure system, sir.
But you find it situated in the low pressure area. It will not be in the intermediate. Anyway, oxygen failure devices are incorporated before the flow meters, okay, so that you know that the oxygen is not flowing, and proportional measures are also there. Flow meter is the beginning of the low pressure segment. Vaporizers fitted next to the flow meters are downstream of flow. Finally, gases and vapors are delivered through the common gas outlet. So this is the path through which the gases come. So the source, then the high pressure segment, then the oxygen failure devices and intermediate segment, then the flow meter going through the vaporizer, and then coming out through the common gas outlet. So if they ask you to trace the path, this is how you should trace. This is how all the gases will flow. Now, because what we decided is the high pressure, intermediate, and low pressure systems that they are beginning. And this is a very common question. Pressure is measured in various units. So, what are all the measures you or units where the pressure is measured you know of?
Kilopascals, PSI, sir.
Kilopascals, PSI,
Millimeter of mercury, sir.
millimeters of mercury, centimeters of water,
Bar and atmospheric
bar.
pressure.
Okay.
PSI.
This is a very, very important thing. So measurement of pressure, you have pounds per square inch, then you have pounds per square inch gauge, then you have absolute pressure gauge. This is a very common question. What is the difference between a gauge pressure and absolute pressure? So absolute pressure is gauge pressure plus atmospheric pressure. Okay? Whereas gauge pressure is what is shown in the gauge. So, PSA absolute is PSA gauge plus local atmospheric pressure. And the EP values of 100 kilopascal is equal to 1000 millibars, 760 millimeters of mercury, 1030 centimeters of water, 14.7 pounds per square inch, which is equal to 1 atmosphere. Okay, so these are all the equal points. So, if supposing you have 1 kilopascal, then it will be how much? Common question. Nowadays, the blood pressure is measured in kilopascals. So, if you have, and your gas values are also measured in kilopascals. So, if you have 1 kilopascal, it is equal to 7.6 millimeters of mercury. So, this value you should remember, or at least 7.5 you can remember. So, 100 kilopascal is equal to 760. So, 1 kilopascal will be 7.6 millimeters of mercury. And effects of altered barometric pressure, of course, what will happen, we will not go into that. This is about vaporizer, how it will deliver. Some history. So, Henry Edmund Gaskin Boyle was the person who published his paper on this anesthesia machine in 1917. But before him, there were two people who actually introduced, but they did not publish. So Boyle got the credit. And then a lot of modifications were done by adding the vaporizer, plunger devices, probing, rotometer, all those things. And this is the original model of that. The types of anesthesia machine, they can sometimes ask you, it is called the intermittent delivery machine. Examples are Enternox apparatus and Mackeson's apparatus. Whereas continuous machine, that is Boyle's machine, if you open the flow meter, until you close it, gases will be going on flowing. Whereas in Enternox, only when the patient takes an inspiration, the valve will open, the gas will be delivered. So it is called an intermittent gas flow machine. Whereas Boyle's machine, Foraker, Draeger, all these things are all continuous gas flow machines. This is the Boyle who developed the machine. This is the older type. This is the newer type of machine. What is this?
Oxygen cylinder manifold.
Oxygen cylinder. Blue color la irukella. What do you say it is oxygen cylinder? The black line irukradella oxygen cylinder. Blue color. It's a nitrous oxide cylinders. Okay, these are all big type, G type or J type nitrous oxide cylinder. Why they are all attached like this in a row? What is this whole area called?
Manifolds.
This is called the manifold row. Okay, this sort of big cylinders are stored in a place called manifold row, and from here you get it through the pipeline to the wall outlet in your OT or in your ICU, wherever you want. You can take it through these pipelines and deliver at the required places. So for big hospitals, we cannot be using very small cylinders and changing them every now and then. So big hospitals having 50 theaters or 20 OTs running at a time, you have to use what is called the manifold room, where all these big type of cylinders. And usually you have two rows, one row in operation or in use, another row as a back or a spare. So all the cylinders will be kept open, and one set of cylinders will be delivering the gases first. When the pressure completely gets emptied here, what will happen? There is a unidirectional valve which will close and open this high pressure area, which will be open, and automatically switching will take place. But there will be an alarm or a visual sign to show that this bank is empty. So that will flicker, and you have to remove all the empty cylinders and replace them. So there will be always one row of cylinders which are in use, the other row which will be in spare or will be reserved. So that is how the manifold room has to be designed. What is this?
Liquid oxygen cylinder, sir.
This is liquid oxygen cylinder, again for supply for major hospitals, where you have to use it in OT, ICU, endoscopy rooms, ward, everywhere. When you have multiple requirements, you cannot be storing in small cylinders like this. So you go for liquid oxygen storage tanks. What is the name for the storage tank?
Vacuum insulated evaporator.
Vacuum insulated evaporator, VAE. Okay. So the short note questions also in the examination. What is this? I told you these are all manifold rooms, and all the central supply has to come to the OT like this. Okay. This is a wall outlet. Okay. What is this?
Shadow pipeline.
Schrader probe. This is called Schrader valve, self-sealing valve. It is color coded. So they may ask you what is the safety mechanism or safety features in this. They are all color coded. Oxygen is white, nitrous is blue, air is gray, and black. All these things are given different colors. Sometimes suction also will be here, it will be yellow. And this probe also is color coded. This is the oxygen hose with the probe. This is the nitrous oxide. This is for suction. This is for air. All these things are different. They have different diameters here. So you cannot insert the oxygen probe into the nitrous oxide, or for that matter, nitrous oxide into oxygen. So we go only into the correct color coded probe only will go into that particular socket. So it cannot mismatch them. What is this? So these two are for wall outlet. This is the outlet socket. This is the probe to carry the gases from the pipeline. And what is this portion? This is the portion which is going to be attached to the machine, anesthesia machine. So this is the delivery point inside the OT. This is the delivery point to the anesthesia machine. So any name for this?
Pin index.
Pin index is these two holes. Entire thing is not pin index. Why do you have these four holes almost similar to that? You find 2 holes here, 2 holes here. This is called the yoke block. Right? This is called the yoke block, which you can attach to the machine. And why they have 4 holes like that? Both are pin index holes only. Okay, these two and these two. Do they look similar or different? Position.
Different, sir.
Different.
Different, sir.
See, in the gap, you can get you should not make a mistake. So both of them are similar only. So you can fix them vertically or you can rotate and then fix them upside also. So whichever way you want to fix, you can fix. Either you can fix it straight like this, or you can make it upside down and then try to fix it. So that is the reason why you have these 4 holes there. What is this? That you would have seen in some of the modern notice. Which theater you are having. Maybe seeing something hanging from here, and you have the outlets all placed in it. This is the older type fixed to the wall. Whereas this is what is called the ceiling pendant wall outlets. Okay, ceiling pendant attached to the ceiling so that you can save space. These are all the outlets that you have. With the electrical points are also there. So you can use your monitor connection, your ventilator connection, all that can be attached here. So what is tuck test? This is a common question they will ask you in the exam.
After
To test
attaching
the connection between the outlet and
The valve. So after you insert the probe here into that, you should make a twist and insert it. And then you must pull, see whether it is stable or it is easily slipping off. Okay. So if it easily comes out, that means it is not properly fixed. So you have to again remove it and then insert it properly and give an anti-clockwise twist. Then only it will get nicely stuck. And then you pull on that. There should not be any leaky noise or it should not fall off. That is called the tuck test. Are there any other tuck tests you know of?
to test for physical cardiac activity, sir.
Again, stability in old age patients.
Timed up and go test.
Timed up and go test for patients' ability to musculoskeletal stability. So these are all the components of the pressure system, high pressure system with the hanger in assembly, pressure gauge and pressure regulator. All these 3 things are coming under high pressure. Intermediate, you have the central pipeline connection and gas power outlet, master switch, oxygen pressure failure devices, oxygen plus valve, second stage reducing valve, flow control. All these things come under intermediate. And flow indicators, unidirectional check valve, pressure release valve, temperature, common gas outlet, they all come under low pressure system. Again, these are the things to show the pictures of that. Not go into that. Okay, another picture which is in the current newer workstations. So the parts of the cylinder, this is another common question in the examination. So what is the beauty of this anesthesia? What is a compressed gas cylinder? What is the definition of a compressed gas actually? How do you define a compressed gas? Of the cylinders we use in anesthesia, they have gases filled at a high pressure, isn't it? So that they can come out when there is a low pressure area. So, what is the definition of a compressed gas?
Storage of pressurized.
What is the pressure and what is the temperature? These are the 2 things that you should remember. Pressure of more than 40 psi. So any gas is compressed and stored at pressure of more than 40 psi at 70 degree Fahrenheit. Then it is called a compressed gas. Any gas which is stored at a pressure of more than 40 psi. Right from 40 psi itself, it's called the compressed gas. So 40 psi and above at 70 degree Fahrenheit, it is called a compressed gas. Okay, so these are the, what is this portion called? This is the valve assembly. Okay, this portion is called the valve assembly. This is the, sometimes you have this long neck. This is the shoulder and body. Okay, so this portion is called the shoulder, the neck of the cylinder. This is the valve assembly, and this portion is the body of the cylinder. What is the beauty of this body of the cylinder? When you want to make any object circular or cylindrical, how do they normally do it? You can take a sheet of paper and fold it, bring the two ends together, then it will become a cylindrical thing, isn't it? Is it made like that?
No, sir.
There is no joint at all. If you rotate the cylinders and see, you will not find any joint. It is not like a sheet that is folded and made round like this. So what is it called? It is a mold completely made on a roller, just like a mold, without any joints. So it is called a seamless cylinder. SEAMLESS, seamless. There is no joint at all to withstand the pressure. If you have a joint welded, that can burst because you are filling gases under very high pressure. So all the anesthesia compressed gas cylinders are all seamless. They don't have a joint at all. Okay. And what is the material out of which they are made? Molybdenum steel. Okay, they are made out of molybdenum steel. Okay, this is a special type of alloy, which is much
MRI comfortable.
which have a very high tensile strength. Okay. And where is wood's material or wood's alloy present in this? The common question they will ask you. It's something called wood alloy or wood metal. Where is it present and what is its use? See, this is a different portion. The valve assembly is a different portion. It is in a conical end. I'll show you another picture and it will have a lot of threads. So this, it will be threaded into this neck portion of the cylinder. Okay? And while threading that, they use this wood metal or wood alloy, which is to prevent any leak. And this has got a property where if the temperature of the ambient temperature becomes too high, and what will happen to the inside pressure? If the cylinder is manufactured in a cold area and then transported to a very hot area, what will happen to the pressure inside when the temperature increases?
Gas expansion.
It will expand, so it can burst. So it will cause an explosion. So in order to prevent that, there is a metal called wood metal, which is incorporated into the screw thread, which is now holding way into the neck portion. So that metal will melt and allow the gases to leak out without the cylinder exploding. Okay, so that is a very important component that you have seen. So you have the components of the cylinder are body, valve, float, stem, pressure relief devices. Now, nowadays we have MRI compatible cylinders which are made of aluminum. Otherwise, they are made of molybdenum steel. And this portion, the top portion is called the stem. Okay. And what is this portion below the stem? Problem is, in our days, we used to open the cylinders ourselves because much of such supply will be there. So we were all trained how to avoid any leak or tighten when there is a leak. Whereas nowadays, you people don't get the chance to see a cylinder getting fixed or being used in the theaters because of the availability of such supply in almost all medical colleges and hospitals. People don't have this, but in the exam they will definitely ask you. So this is the stem which you have to open And this is called the gland nut. That will be a hexagonal nut which is holding it below. Sometimes this nut may become loose, so we have to tighten this. Okay? This is the portion which is going to be fixed to the yoke assembly to deliver. The gases go out through this port, and these are the pin index pins which will be projected and holes which will be in the valve assembly, which will have to be fixed into the pins that will be protruding. And on the back side of this valve assembly, you have a depression where you have to use that screw to hold it. And this is the pressure relief device, which will automatically let the pressure if the pressure increases inside. So I'll show you another picture where you can find out. This is how the machine will be. This portion is the machine portion. These pins will be projecting like this. And these are the holes in the valve assembly. So this has to go inside to fix the cylinder. And this is the hole through which the gases will be released. And once you open the stem, the gas will start coming out from the cylinder and enter through this port. And this is the arrangement of the pin index. So the common question they will ask you is, what is the pin index number for air, oxygen, nitrous oxide? So the various numbers. Oxygen, air is 15, oxygen is 25, nitrous oxide is 35. So you can remember air 15, oxygen because we write this as O2. So remember 25. Nitrous oxide you have N2O, 2 nitrogen, 1 oxygen. So 3 elements are there. So it is 35. So 15 is air, 25 is oxygen, 35 is nitrous oxide. Similarly, carbon dioxide you get it in 2 different strengths. Less than 7% we call it as 2,6. More than 7% we call it as 1,6. And cyclopropane, which is not used nowadays, but we used in the older days, we call it as 3,6. So 1,6, 2,6, 3,6 are for carbon dioxide and cyclopropane. And ethylene, of course, we don't use it. Which, what is the pin index? What is the cylinder which does not have a pin index?
Helium, sir.
Helium does not have. And what is the pin index for single digit pin index? Which gas has N-tenox has got? Very good. Excellent. So this is the color coding for various things. So this is how, this is the picture to show you clearly how the pins you have to fix, which goes into the, this is the screw which I have told you. This valve assembly will be fitted into the gas cylinder body through the screws. So when you tighten it, there will be a metal which will be applied to this, which will leak or which will melt and allow the gases to leak if the temperature is very high and pressure is builds up inside. And this is what is called the retaining screw, which you can tighten to make the cylinder get mounted with the what are the pin dimensions? The dimensions of these pins are, they are 4 millimeter in diameter and 6 millimeter in length. These pins which are there in the yoke assembly, they are 4 millimeter in diameter and 6 millimeter in length. I don't know how many of you have had the chance to see this. What are these things?
Openers, sir.
With keys.
Cylinder openers.
Yes. What is this shown here? These are all key. They should be called as key for opening. Just like we open a lock, we use this key for opening the cylinders. Now you find these keys have got different holes and a spanner-like thing. What is it for? This one and this one, they are all almost similar. So this is a hole through which you have to, the stem will come. You have to insert the key there and rotate it anti-clockwise for opening and clockwise for closing. So if you rotate it this way, it will close. If you rotate it on the opposite anti-clockwise direction, it will open. And this portion, the spanner, is the portion for tightening the gland nut, which I showed you in the earlier picture, which is there. That hexagonal nut will be there. But I have a picture to show that clearly. So what is the filling ratio and what is its importance? This is another common question they will ask you with regard to the cylinders. Filling ratio. Is there a filling ratio for oxygen? Filling ratio is there only for gases which are in the liquid form, which have to vaporize, like your nitrous oxide. Okay. So when you have a gas which is in the liquid form, you cannot fill it to the maximum level. You have to fill it only about 75% of the capacity of the cylinder, because the gas will expand and form a vapor under pressure. So you have to fill it only about 75%. The filling ratio is the ratio between the volume or weight of water that the cylinder can hold to the volume of the gas that you can fill. That is the filling ratio. So what is the value for carbon dioxide? Because carbon dioxide is also coming in a liquid form. Nitrous oxide and carbon dioxide are the two gases or vapors which are coming in a liquid form which vaporize. The filling density is the percentage ratio of weight of the gas in the cylinder to the weight of water that the cylinder can hold at 60 degrees Fahrenheit. This is a protective mechanism so that if the ambient temperature becomes too high, then there will be enough space for the gas to expand without causing too much of an increase in pressure. That is why you should not increase or fill the entire cylinder with the nitrous oxide liquid. Then there won't be any space for expansion and there is a variation in temperature and the cylinder will burst. So you have to fill only 68% of the weight of the water that it can hold. So the value is same for both nitrous oxide and carbon dioxide. That is the catch in the question. So what is service pressure and what pressure cylinders are checked for leaks? Okay. Cylinders are checked for leak and retention of structural strength by testing to a maximum of 1.66 times their service pressure. Service pressure is defined as the maximum pressure to which the cylinder may be filled at 70 degrees Fahrenheit. So it is the maximum pressure to which a cylinder can be filled with the gas at 70 degrees Fahrenheit. What other tests are done and at what interval? We have to periodically test the cylinders so that they don't burst or cause an explosion. So the other tests that are done are tensile test, flattening test, bend test, and impact test. These are carried out at least 1 out of every 100 cylinders and once in 5 years. This is done at least once in 5 years. These cylinders have to be tested for their tensile strength so that they don't cause any damage. So what is critical temperature and critical pressure?
The temperature at which the gas can be in liquid form, sir, above which the gas turns into vapors.
Critical temperature is the temperature for which you cannot compress the gas into liquid, whatever. So the critical temperature of a substance is the temperature at and above which vapor of the substance cannot be liquefied, no matter how much pressure is applied. Okay. So temperature at or above which vapor cannot be liquefied. That is called the critical temperature. What is critical pressure?
Pressure above which the liquid and gas exist at same temperature.
Substance is the pressure required to liquefy the gas at its critical temperature. What is medical air? Nowadays, most of you may be using oxygen and air mixtures instead of nitrous oxide. The work rate is going slowly, going out of vogue. So majority of the anesthetists are now depending on medical air. So air that has no detectable liquid hydrocarbons or less than 25 parts per million of gaseous hydrocarbons, less than 5 milligram per cubic meter of particulate matter of 1 micron size or greater at normal atmospheric measure the dew point of 50 psi of less than 4 degrees is called medical error. It's a big definition for that. So at least you must remember that it should not have more than 25 parts per million of gaseous hydrocarbons. That is a very important thing. And low levels of nitric oxide should be found in the ambient air, but it may improve oxidation because it will cause, nitric oxide will cause, what is the effect of nitric oxide? The vasodilator. Okay, so it will cause more blood flow, they help in oxidation. So this is the formula when you are using oxygen in the air mixture. What percentage you will get is to know that you should know this calculation. I don't know how many of you are utilizing this. So the formula that you have to use is you have to use both the concentration you will attain is when you use oxygen you get 100%. And when you mix it with the air, it has got only 20.21% or 21%. But the total volume that you use, oxygen per liter and air per liter, you have to combine. For example, you use 2 liters of oxygen and 2 liters of air. You will get 2 into 100 and you will get 2 into 0.21 air. So you will have, and the volume total you use is 2 plus 2. So 100 into 2 plus 21 into 2 is 42. So you will have 242 divided by 4, you will get almost 60.5% of oxygen. So that will be the ultimate FiO2 that you will get is almost 60%. So if you want to get lesser percentage of oxygen, you have to increase the flow of air. If you want higher percentage, you have to decrease the air. That is the simplistic way to remember. Then this is another common question. What is adiabatic change and what is Joule-Thomson effect? So adiabatic change in Joule-Thomson effect. When a gas is subjected to sudden compression, the heat energy is produced rapidly, and the reverse occurs when there is a sudden expansion. So when you open a gas cylinder, what happens? The gas which is under compression that suddenly gets released and the pressure drops. But at the time there is no exchange of energy with the surroundings. This is what is called adiabatic or adiabatic change. There is no loss of energy or gain of energy. That if you say that word also, they will accept, the examiners will accept. So the moral of this is whenever you open a cylinder for use, you should open it very slowly. You should not rapidly open the cylinder. Then if you rapidly open, there is a possibility of explosion. So you have to slowly open. Whereas in Joule-Thomson effect, where gas is allowed to escape through a narrow opening, it will cause a sudden drop in temperature. So this effect you will see in the nitrous oxide cylinder, where you will find there will be ice formation around the valve assembly. So that happens because when you allow the gas to escape through a narrow opening, there is a drop in temperature which will solidify the water vapor in the surrounding atmosphere and dew formation will happen. So that is what we call Joule-Thomson dew formation. You can remember that. So ice formation will be there due to Joule-Thomson, whereas explosion is possible by adiabatic change. We have to open the cylinder very slowly. If you say these 2 points, I think it will be true. So this is the what you see here. That's a workstation usage. I think all these things look like massive specimens for most of you. So this is what you call the dummy plug. When this the whole thing is called the yoke assembly, where the cylinders are fitted. This is the retaining screw. This is the gate for holding the cylinder. So whenever you don't have or use a cylinder or it has become empty and you don't have a replacement, you have to always keep that inlet port covered with this dummy plugs. Otherwise, dust and oil may get deposited there, and when you open the cylinder, explosion can happen. You can see the name of the gas for which this is used here. This is CO2, used in the olden days. This is cyclopropane, orange color. So these are two really museum specimens which are now not used. So they are all close to the dummy plants. You can see that this, but this is the way usually it is done that. And the pin index system was introduced in the year 1952. Some examiners are fond of asking who is the person who introduced this pin index system. Anybody knows the name of the person who invented and introduced it into clinical practice? Three, four, five, 6, 7, 8, 9, 10 seconds. No answers. It's called Woodbridge. The person's name is Woodbridge. Woodbridge. Tamil Tanyavanga, Marathalla Palamukna, Woodbridge is the person's name. So this is a closer view of the chunk. So this is the ports for releasing the gases outside. These are the pin index poles. So there is a closer look of that looks. And there will be something here. You find there's a depression surrounding here. What should be kept there?
Product seal.
Product seal. Excellent. So, limitations. When some examiners are fond of asking, how can you cheat the pin index system and pump the wrong cylinder? So the wrong cylinder can be placed if you put two washers here. Instead of one product seal, if you put two product seal, the gap will be filled. And if all the pins are broken, or the holes in the cylinders are too deep, then you can cheat the yoke and it's a wrong cylinder. This then immediately you should answer this. This is a very common thing which you are seeing every day in your machines.
Gordon Scotch.
Gordon gauge, pressure gauge. Okay, so this is. They can ask you what are the safety features in this pressure gauge. Can you enumerate the safety features of the pressure gauge? It is color coded, white, oxygen, and the name is written and caution is given as no oil to be used, and it shows the limit of full cylinder, and it gives you a warning when refill. Supposing you reach 500 psi, you have to get ready for refill. Okay, and all these things are written here. Open the cylinder valve slowly. This is where you have to remember adiabatic change. So that caution is also written here. If you open it fast, there is a chance it can explode. So open cylinder valve slowly. This for adiabatic change. Use no oil to prevent explosion. Name written and all the various levels of filling. This 1000 psi is half full. So this is full, 3/4 full, half full, and ready for refill. All these things. And if at all any explosion happens, it will happen at the back. It will not happen on the front glass. Okay, so the back cover which will explode, and that is how this will happen. This is the Gordon gauge principle. So when there is a high pressure coming here, there is a coil tube. This will straighten. This will become straight, and this is based on the toy which the children use. This is called the noise maker. Okay, when you blow air into this whole tube will become straight, and once you leave the pressure again, it will coil and come back to its normal position. So this noise maker or the toy which is used by the children, this is the basis for this particular Gordon gauge. Okay. And this is the person, Eugene Gordon, who designed that. And this is the nitrous oxide cylinder. Again, you can see the color coding, you can see the pressure gauge, everything is there. So safety features in the cylinder pressure, gauge is usually color coded, name and symbol of gas written. The Gordon tube ruptures, gas is vented from backside. Gauges are angled and placed in such a way that it can be easily read by anesthetists. And instructions like no oil and open the valve slowly are written on the gauge. So these are all the safety features that the journalists may ask you. This is the pipeline inlet connection which are there. So this is the what is called the diameter inlet safety system. So instead of the DO block which I showed in the earlier picture, this is the modern method of connecting the wall outlet hose. This is the high pressure hose which is connected from the wall outlet into the machine. So these are all called the diameter inlet safety system. Pipeline pressures are usually 50 to 55 psi. So they may ask you why the pipeline pressures are kept at this level. Why can't it be straight away reduced to the low meter intermediate pressure? Why it is kept at 50 to 55? Wherever you have a wall outlet with the pipeline outlet, you will have the pressure at 50 to 55. So that was the pressure in which all the pneumatically driven ventilators were working. All the olden day ventilators were driven by a pressure of 50 to 55 psi. So they kept it for driving the ventilator. So how to calculate the amount of gas in the nitrous oxide cylinder? So that is by using the Avogadro's hypothesis. So 1 gram molecular weight will occupy 22.4 liters of gas at standard temperature and pressure. So the weight of the nitrous oxide cylinder is 5.6 kg. When you fill it up to 68%, that is the filling ratio. But the bare or tare weight, which is empty cylinder weight, is 4.5. So if you subtract this from the filled cylinder, the weight of nitrous oxide is only 1.1 kg that you are filling. And the molecular weight of nitrous oxide is 44 grams. Will occupy, that is one molecule of nitrous oxide weighs 44 grams, will occupy 22.4 liters. So in 1.1 kg of nitrous oxide, you have 1100 grams of nitrous oxide. So 22.4 into 1100 divided by 44, you get 560 liters. So the total amount in volume of nitrous oxide will be 560 liters inside a cylinder. So if we give 2 liters per minute, that cylinder will last about 280 minutes or 4.6 hours. So remember this calculation. Sometimes you will do very well in the exam, they may ask you. Now, how to calculate the volume of oxygen in a full E-type cylinder? Based on the Boyle's law, at constant temperature, the volume of a given mass of gas is inversely proportional to the absolute pressure. We know the volume of E-type cylinder is approximately 5 liters. So if the service pressure at which the cylinder is filled is 2000 psi, 2000 into 5 into 15 into 5 V2. So using this, we can say if you use 2 liters, 3 liters of oxygen per minute, and the E-type cylinder will last about 220 minutes. That means 660 capacity will be there. So how can you calculate the duration of supply from an E-type cylinder? So that is a much more easier method to calculate. So by using this equation, pressure in the cylinder divided by 200 multiplied the liter of flow per minute. That will tell you how long or what terms of hours and minutes, how long the supply can last. So the example is, if the cylinder pressure is 1000 psi, we are using 2 liters per minute, 1000 divided by 200 multiplied by 2, which is 400. So if you divide that, the cylinder will last for 2.5 hours. So this is one method of calculating the duration with which the supply will be there. This is the exact amount of liters with which you can calculate. So what are the oxygen failure safety valve systems that are there? That is another question that they may ask you. If pressure sensor valves are there, then the oxygen supply failure alarm is different from oxygen proportionating system. So there are two important things with regard to oxygen. One is there may be a total supply failure. So that has to be indicated to the anesthetist or the person handling the machine. That will be in the form of an audio-visual audio whistle or a visual effect in the form of a red light or blinking light like that. Whereas oxygen proportionating device is to make sure that you get at least minimum 25% oxygen, whatever gases you are using, especially if you are using nitrous oxide, there should be always a safety mechanism by which you will get at least 25% of oxygen. So this is called the Bowman's whistle, the pneumatic alarms. They tell you about the complete supply failure. So the Bowman's whistle is a supply failure, whereas the other method like LIP 25, what you see is all for proportionation. So this is the older machine. When they remove the top, this is what you will see. These are the pressure regulator. This is the connection to the closed circuit. This is the oxygen flush. These are all the current going to the flow meter. So this is where the low pressure alarm system will be there. So the oxygen failure device or alarm is a slave alarm. So whenever there is a drop in pressure, automatically it will cut the nitrous oxide supply so that you don't get a hypoxic mixture. This is the loop that you will have when the table of the whole Boyle's machine. The principle of a pressure regulator, how it is working, it's another important question that they may ask you. So this is the way the high pressure gas will come in and it will be going to a larger area. So high pressure in a smaller area transmitted to a larger area will automatically reduce the pressure. Okay? That is how the principle of pressure regulator works. There are various types of old pressure regulators now to be learned at the time of the exam. Safety features of pressure regulators have safety valves. So whenever the pressure inside the regulator increases enormously, there is a relief valve. Everywhere in the machine, if you see, whenever there is a excess pressure beyond a particular limit, there is always a way to leak. Just like your pressure cooker, when the pressure increases, the top weight gets lifted up and all the pressure is released. Similar to that, you have a safety mechanism in all parts of the anesthesia machines. Whenever the pressure increases beyond 70 psi, this is the safe limit. Supposing they ask you what is the safe pressure limit beyond which it will start relieving or leaking, it is 70 psi. So the oxygen flush, the common question is how much of oxygen will be delivered? This will be between 35 to 75 liters per minute. That is the standard answer. But what pressure it will be? It will be little high pressure, so you may cause barotrauma, it will cause dilution of inhaled anesthetic. If it is accidentally activated, then you will have the flow coming, mixing with the mainstream and causing problem. And there can be internal leakage and sometimes the flush may get stuck. So there will be something like a button which you push that may get stuck. But anyway, there is always a relief valve which can save you. So flush valves for gases other than oxygen are not permitted. Oxygen flush can be activated regardless of the machine which is on or off. This is what is called the auxiliary oxygen delivery system in the modern anesthesia machine. In the older machine also, oxygen flush can be activated in any way. And the pressure at which it comes is the pipeline pressure. It is almost 60 psi pressure at which it will be delivered. So 60 psi, 35 to 75 liters volume per minute are the two important points that you should remember with regard to oxygen flush. Okay. So because of this high pressure, whereas when it comes from the flow meter, it is only about 15 psi, 14 to 15 psi. So it is reduced almost by 1/4 the low pressure segment. This is in the intermediate pressure segment. So it is always likely to cause oxygen flush, especially when you want to fill up the reservoir bag in a patient connected to the breathing circuit. Don't use the oxygen flush to either fill up the bellows of the ventilator or your breathing circuit or reservoir bag. So that's a very dangerous practice. It's shown here. This is the machines which you are nowadays very familiar with. Time. We will be power switch, on off switch for all your modern anesthesia workstation. Okay, master switch to activate the workstation. So flow meters, nowadays we have twin flow meters. For oxygen and nitrous oxide, you have double flow meters. For air, you will have a single flow meter. But the purpose of the double flow meter is for low flow anesthesia. So the first flow meter will be up to maximum 1 liter. Subdivisions of starting from 10, 20, 30, 40, 50, 100, 200 like that. So for low flow anesthesia, nowadays we have 2 flow meters for both oxygen and nitrous oxide. And what are the factors governing the flow? This is another question. They are all pre-calibrated. You cannot use one flow meter for another gas, and there is a pressure drop across the constriction. So at low flow, the flow is laminar, so viscosity becomes important. At high flow, it is turbulent and density becomes important. So laminar means they all go with straight one by one without any clash. Whereas turbulent is like the auto rickshaw coming in all directions from anywhere. So it is a turbulent. Turbulent flow, density becomes important. Laminar flow, viscosity becomes important. Is shown here. This is the preferred digital system, solenoid valves and control valves. This is another type of flow meter used in some modern machines. And this is a classical workstation. You can see the power on-off switch is here. Here the apparatus attached, and we have pressure gauges both for pipeline as well as for the cylinder pressures, which were not there earlier. Pipeline pressures are not shown. So by seeing the pipeline pressure, you know whether the pipeline pressure is normal. This is the auxiliary oxygen outlet. This is the place where you can deliver oxygen to the patient even if the switch is not switched on. This is the auxiliary oxygen outlet. This is a self-contained flow meter with its own flow control valve, indicator and outlet. Short tube with the maximum flow that you can deliver is only 10 liters per minute. So this is the flow meter tube for that. You can give only 10 liters per minute. Usually on the left side of the machine can be used to supply oxygen to the patient without turning on the machine. Older machine, it works on the pipeline supply. The newer one works on cylinder as well as pipeline supply both. Okay. Hypoxia prevention devices, minimum mandatory oxygen flow is important. So that is how the ratio, the link 25, all these things are prevention of hypoxia. So the mandatory flow. This is the link 25 system, a chain connecting the oxygen control knob as well as the nitrous oxide. So once you rotate the nitrous oxide once, oxygen will rotate 4 times. So that is how you prevent it. All the details are not required. You just say it is a hypoxia prevention device. Okay, enough. And some of the other machines have got what is called oxygen ratio controller, which will also deliver the required amount of oxygen. Then there are a lot of unidirectional check valves, and this is the pressure relief valve, which you will find on top of the machines. That will also be useful. So this is the common gas outlet. This is what is shown here in the common gas outlet. So this is the older machine. This is the newer machine, and we can switch it down to circle system as well as to, if you want to use Mengele system or spontaneous ventilation or a pediatric circuit, you have to turn the switch to common gas outlet. This is the flush type oxygen valve. This is an emergency oxygen flush valve. So you just press it and use the oxygen. Then make sure that it comes back to the original position. This type of button only will get stuck in the middle, and that will constantly deliver oxygen, which will cause dilution of the mixture that you are using. Some outlets use 15 ml female slip joints and some others use 20 mm male connector. So it is difficult to accurately disagree. That is also another important difference. And this is where I told you, I show you the difference between the ether bottle and trilene bottle. So some of the older machines have this sort of flow meter. And the oldest machine had 4 flow meter tubes. One for oxygen, for nitrous oxide, one for cyclopropane, and this one which has been dummied was used for carbon dioxide. So if still some hospitals have the very old machines as an initial specimen, we will have the 4 flow meters for 4 different gases. And this is the old boils bottle or ether bottle. You can see this is larger in size because potency of ether is much less compared to trilene. So because trilene is more potent and more depressant, you don't have to use it in a larger volume. So they have reduced the capacity. And this is the lever with which you can switch it on and switch it off. This position is completely off. Then you have arbitrary 1, 2, 3 markings and on. So you can allow partial gases, fresh gas flow coming into that by operating this lever. If you keep it in full on position, all the gases, both oxygen and nitrous oxide coming from the flow meter will enter through this bottle and then go out and get delivered here. And this is the common gas outlet. And there is a rotating knob here. This is called the driving lock or the control lever, control knob for changing from open circuit to closed circuit. So by rotating this only, you can operate the soda lime canister circuit without operating this. So when you operate this driving lock will not be moving. So there is a reaction going on between trilene gas and the soda lime. If we use trilene in the presence of soda lime, what can happen? You can get a dangerous poisonous gas called phosgene. PHOSGENE, phosgene, which is a neuropoison. It will kill the central nervous system, neurons, and the patient will go into coma. Okay? So patients, you should not by mistake operate the deliver trilene to the patient when you are using closed circuit with soda lime. So this lever will be in the off position. You cannot operate it. So this is another name for this knob is also trilene lock. So these are all something which is very old. And this is the lever to isolate the bag. So some examiners, if you are very good and you have answered very well, they may ask you what is the purpose of this particular knob that is projecting there. This is for isolating the bag. So those when they are using cyclopropane, what they used to do is they used to allow a mixture of oxygen and cyclopropane and occlude the patient breathing circuit. This end they will occlude and then fill up this bag fully and then rotate this knob. Then what will happen? The bag will be fully filled with the gases mixture and then they will keep the oxygen and the face mask on the patient and open this knob. Then the patient will start breathing the mixture of oxygen and cyclopropane from this bag. And with 4 breaths, he is supposed to become unconscious. That much powerful infection agent was cyclopropane. That's one of the method of using this. And you can also use this for hanging the bag for drying. So this back bar is one which is there where the vaporizers are all attached. Nowadays, in the modern vaporizers, you can use only one vaporizer at a time. So it is called Anesthetic or lock mechanism. And the color coding for vaporizers are all there. And then from after the vaporizer, you get a common gas outlet and you go on to the breathing circuits. So breathing circuits are, even though they are part of the anesthesia delivery system, they cannot be added exactly into the part of the anesthesia machine. So breathing system is separate. So anesthesia machine stops with the common gas outlet. So whatever tube you want to use, you can choose and attach it to the machine. So the actual part of the machines are from the central supply or the gas cylinder supply, pressure regulator, flow meter, vaporizer, this is all which consume the parts of the anesthesia machine. I think we are running out of time. We are almost become how much?
There is some disturbance in the voice, sir.
Hello?
Hello, sir. There is some disturbance in the voice. Now it's better, sir.
Okay, I think the mic is moved a bit. Shall we stop it here?
Yes, sir. Can we have this IV fluids and drugs discussion for next Tuesday, sir?
Yeah.
Okay, sir. So, thank you, sir. Thank you for a very, very extensive and very useful discussion on Boyle's machine and anesthesia workstation. I hope all the students have gone through a very useful journey of over 100 years, sir, now. To your slides.
Yeah.
Any questions and feedback from the students, please? Any doubts or comments or suggestions or questions from the students? You can all unmute yourself.
Yes, sir.
The problem is nowadays people don't get an opportunity to use the cylinders and fix them to the machine and open them and use them. But the practice is not there because you don't have all the supply from the manifold and all outlet is there. So the common questions they ask are all, of course, very old-time questions. They may ask you about cracking the cylinder. Anyone knows about what is cracking the cylinder? So whenever you want to attach a E-type cylinder to the machine, you are supposed to open that valve stem and allow some amount of gas to leak out so that that port, which is kept in storage, if there is any dust or oil particle, that will be blown out. And you are supposed to hold it in such a way that the gas flow is opposite to you, not on your face or your body. And then close it and then fix it to the machine. That is what is called cracking the cylinder. All the old-time theatre assistants or ODAs will use to do that regularly. That is one of the common questions the examiners may ask you. Continue with
it was like reading whole of Dosh and Dosh, sir. So everything. Got all the points, sir. Really nice.
So we will see the drugs and other things in the next class. Okay. So any questions or any doubts you have, you can ask now or you can put it down. Rajesh, who is want to start? See,
I think students are a little bit thinking about where to start and how to articulate their questions. So I'll request them to submit their questions in the WhatsApp or our group.
Yeah, you can do that.
I will upload it in our YouTube channel so that they can post their comments and views and ask the doubts also. The YouTube channel will become a very good medium for us to capture that doubt, sir. And thank you so much, sir. Thank you so much, Masti Madam, and thank you so much, Rashi Madam, and thank you,
Vasanthi, for holding
Nice to listen to you, sir. Thank you, sir.
Thank you, Madam, and thank you all the students. Sir,
can we 13 degrees, sir.
Okay.
Can we sign up today's meeting, sir?
Yeah, thank you.
Yeah, thank you, sir. Thank you so much.
Thank you, sir.